Okay. Good afternoon, everyone. I'm Dr. Praveen, Manager Market Access and Advocacy, SAT India. On behalf of SAT and AWO Alliance, we welcome you to this live webinar series on advances in casting and splinting. A quick introduction about SAT and AWO Alliance. SAT was formerly known as BSN Medical. SAT is a global hygiene and health company headquartered at Stockholm, Sweden, and has presence across 150 countries. While AWO Alliance is a developmental non-profit organization dedicated to improving the care of the injured in the low and middle income countries. Now, this session is a series of live webinar programs happening every Saturday from 1 to 2 p.m. over the next 2 months. And this is first such program. In today's session, we have participations of around 1,000 orthopedic surgeons, not only from India, but also from other countries across Asia Pacific. The topic for today's session is conservative treatment of fractures, challenges and tips for everyday cases. Now, I would like to welcome Dr. Devashish Barik, who is our keynote speaker for this session. Dr. Barik is a professor in orthopedics from NKP Salve Institute, Nagpur. Joining the speaker, we also have distinguished panelists chairing the session. I would like to welcome Dr. George Thomas, who is the chairperson of AWO India, and also orthopedic consultant at St. Isabel Hospital, Chennai. We are also privileged to have Dr. Ram K. Shah, Regional Director, Asia Pacific, AWO Alliance, and also Professor at Janki Medical College, Nepal. We welcome you, Dr. Shah. We are also privileged to have Dr. Claude Martin, who is the Managing Director of AWO Alliance. We welcome you, Dr. Claude Martin. So the program flow would be, the speaker session along with the panel discussion would be held for around 40 minutes, and that would be followed by a Q&A session. So I request all the participants to post their questions on the question bar you can see on the page. And at the end of the speaker session, I'll be taking off all the questions and addressing it to the speakers and panelists. So now I would request Dr. Barik to deliver his talk on the topic. Over to you, sir.
Yeah, okay, thank you. Very good afternoon from India. Very good afternoon to all the esteemed panelists. Today, the first masterclass, the topic is conservative treatment of fractures, challenges and tips for everyday cases. Myself and the panelists have no potential conflicts of interest to report here, and the views and opinions expressed in this presentation are those of the individual presenter and not endorsed by anyone. Let's outline the masterclass today. We'll be starting with the learning objectives, a brief introduction, basic tenets of fracture healing, looking at fractures, those necessitate operative management as well, and then looking at operative versus non-operative management, challenges and limitations of non-operative management, tips to overcome these challenges and limitations, some interesting case series with clinical examples, and then we'll look at advantages and dangers of non-operative management and cast application. So the learning objectives here would be to identify the common fractures that can be managed conservatively, to understand the challenges in conservative management of fractures, to understand the advantages and disadvantages of non-operative fracture management, and to identify and learn to avoid complications during the non-operative management of fractures. As is commonly perceived, non-operative or close treatment of fractures does not equal to no treatment. The two pillars for such fracture, and then supporting it with good mechanics so that the fracture heals to a predictable outcome. The basic tenets of fracture treatment would be to reduce the fracture, to hold that reduction, and to maintain the reduction till the fracture unites. And all these can be achieved either non-operatively or operatively. The fractures of necessity. Now, why do we call them the fractures of necessity? They are called fractures of necessity because these fractures require operative treatment. And we should not try to treat them non-operatively. These are all displaced articular fractures, most segmental fractures, all compound fractures, and those fractures that are associated with neurovascular deficit. Because in these fractures, achieving and maintaining reduction is difficult, and malunions can be pretty difficult to manage. I mean, imagine having an articular fragment which is malunited. So most of these fractures would require surgical treatment. The fractures of necessity, just looking at a few examples, this is not a descriptive it's the pertrochanteric region of the femur, displaced fracture neck, femur, supracondylar femoral fractures, and sharp femur fractures. Sharp femur fractures because these fractures are difficult to immobilize in a cast because the proximal joint cannot be immobilized well conservatively. But there are some inherent risks with operative treatment. With any operative treatment, there's a surgical risk, there's an anesthetic risk. There are implant issues and hardware complications like breakage of guide wires, K-wires, jammed screws, anything. Infections, of course. Cosmesis is important, especially in the exposed parts where the scar healing may not be adequate or may lead to a hypertrophic scar. Surgical treatment is always more costly. And in orthopedics, we must always consider the need for a second surgery. For example, all these patients may require an implant removal or a bone grafting to augment fracture healing and augmentation of fixation. So the basic premise for any non-operative approach in fracture management, we should ask ourselves two questions. Can we accurately and acceptably reduce this fracture? And hi. Yeah. Yeah, can you see my... No,
Yes, Dr. Barik.
I'm fine. Can you see the screen right now?
Yes, we can see the screen.
Hi, can you hear me? Yeah, okay, sorry. Yeah. The current indications would be patient is unfit for surgery or the patient is refusing surgery. But in prevailing situations where the surgical treatment is detrimental and risky both for the doctor and patient, like we have right now in the COVID-19 pandemic situation. But the question that we must ask ourselves is, do we ever give the option of non-operative treatment to our patients? And it has been most often seen that the operative option is usually given as a deliberate first choice and not the conservative management or the non-operative management. But whenever we offer a conservative management or a non-operative management, we must take some few things into consideration. The first is the infrastructure. There are setups where the infrastructure is very basic, without any advanced equipment and without any imaging modalities. In these basic infrastructures, the fracture management would mostly focus on the non-operative type. And it's important here that the doctors and surgeons there are well trained in the non-operative management. In the better setups or better than average setups where all equipments are available, implants are available, the team has to take a judicious call between operative and non-operative management. Whereas in advanced setups where everything is available from equipments, implants, imaging, there has been operative over-treatment, and it has been seen that even fractures that may be conserved are actually treated operatively. The second consideration for the doctor is that one must understand the fracture morphology. And that would mean whether the fracture is comminuted, segmental, and the fracture patterns. The second consideration is bone and the fracture location. In the proximal tibial fractures or metaphyseal fractures, one can anticipate good bone healing and early union. So one must take into consideration the location of the fracture. And most importantly, it is the patient factors which also must be considered, because when you treat a patient conservatively or non-operatively, it's very important that these patients are very compliant with instructions and follow-ups, because if they are not doing that, then it usually leads to a poor result. So let's look at some fractures which can be conserved. Most undisplaced and stable or incomplete fractures can be treated conservatively. Transverse or short oblique fractures also are amenable to conservative treatment. Fractures in paired bones, especially those that are not at the same level, for example, in the forearm and in the leg, where you have the paired bones, if the fracture is not at the same level, then they also can be conserved. Most pediatric fractures can be conserved, taking advantage of their healing potential and the thick periosteum. And in some special cases, for example, someone has a pathological fracture with following osteomyelitis, and there is a good incorporating sequestrum. So even these cases can be managed conservatively. Let's look at some examples. Say in the upper limb, you have the Colles fracture, the fractures of the clavicle, metacarpal, humeral shaft fractures, proximal humeral fractures, and undisplaced forearm fractures. So this is a Colles fracture, which is classically extra-articular metaphyseal, treated very well with a cast. You're able to get the reduction and even hold it well. The metacarpal fractures, here the fourth metacarpal has a spiral oblique fracture, but because the third and the fifth are intact, again, these patients do well with conservative management, and the fractures go on to heal well. Clavicular fractures, at injury, they may look quite displaced, but then over time, you can see that at the end of 3 months, there is good solid union. In the lower limb, the proximal tibial fractures, especially those that are minimally displaced or undisplaced, but are extra-articular. These fractures can be treated conservatively. Tibial shaft fractures, like transverse fractures, we've seen Sarmiento's series, they treated all the shaft fractures, even grade 1 compound fractures conservatively, with very good results. Undisplaced fractures of the patella, fractures of the metatarsals, phalanges, and sometimes undisplaced malleolar fractures, especially if they are only the medial malleolus or only the lateral malleolus. These fractures may be treated conservatively. So that was an example of a proximal tibial fracture and a distal tibial undisplaced fracture with the fracture of the lateral malleolus, and fractures of the patella like this, which are transverse, simple, non-comminuted. You can see that by about 6 weeks, they go on to union. So the modalities of immobilization in non-operative treatment, we've had plaster of Paris since the 18th century. And recently, we have fiberglass and polyester casts. Splints, they may be ready-made or ready-to-use splints, or even thermoplastic splints, which are easily made in any clinic. Traction, skin and skeletal traction has been used to reduce fractures and even hold reduction. But these techniques are no longer used because they require hospitalization and the patient is bedridden till the fracture unites. However, in special cases like in fracture shaft femur in children, one can still use the gallows traction. Bracing for humerus fractures is very commonly used. We have the Sarmiento's brace, we have the coaptation splints, and very rarely bed rest. I think that's only restricted now to undisplaced Rayami fractures. But there are certain challenges in conservative approaches. That is, most importantly, a wasting and atrophy of the muscles that are immobilized, joint stiffness, But luckily, these are reversible with good physiotherapy. Other issues like cast material irritation, hygiene issues, or skin problems, all of these can be overcome with better casting materials. Now let's look at some limitations of conservative management. One may be able to reduce a fracture well, but the reduction may not be very precise because it is an indirect reduction, it's not a direct reduction. And once the reduction is achieved, maintaining stability also is challenging because you are trying to hold the fracture with a cast or a splint, and there is an intervening soft tissue of muscles and tendons between the bone and the splint. So stability also may be challenging. Because the reduction may not always be anatomical, there may be some malunion, and these patients usually require more OPD visits because they need to be followed up, and one needs to see whether they're taking care of the cast, they're elevating the limbs, the cast is not loose or broken, and they require more radiographs because the position of the fracture fragments needs to be monitored. So what are the tips to overcome these challenges and limitations? It's important that when we immobilize these fractures, we immobilize only the joints that are necessary. We advise the patient to do good isometric exercises to reduce muscle wasting. And it's important that there should be a judicious conversion to splints. One must always exercise the uninvolved or the unimmobilized joints, and weight bearing in the lower limb should be started in a graded manner as early as possible. So looking at both of these options of fracture treatment, can we really say that which is easier, the surgical management or the non-operative management? Well, it's more difficult to achieve reduction in the non-operative management. It's more challenging to maintain the reduction. And sometimes these fractures take more time to heal. And these patients require repeated assessments. And the non-operative treatment is quite challenging if the patient is not compliant. And especially they need to be hospitalized if a fraction is used to reduce and maintain the reduction. Now let's look at some good clinical cases and examples. This is a night watchman fracture of the distal diaphysis of the ulna. The fracture is slightly displaced, minimally angulated, but impacted. And it goes on to heal well. Within 3 weeks, you can see a good callus. The proximal humerus. This is an elderly lady. I think she's 65 years of age. She came to us very recently when this lockdown and the COVID pandemic had started. This is a 3-part fracture of the humerus. This is the X-ray on the day of injury. This is at 1 week. So we called her back for X-rays. She was given a shoulder immobilizer. And you can see that the fracture is still maintaining position, not gone into varus. And this is at 3 weeks. And this is a shoulder immobilizer. We've also given a dynaplast strapping from the humerus to the chest. If you look at literature for the proximal humerus, this is a meta-analysis published in the Journal of Shoulder and Elbow Surgery in 2018. And they concluded that it is recommended that non-operative treatment is given to elderly patients with displaced proximal humeral fractures, and they were doing better than those treated surgically. Another meta-analysis, again, of 254 participants, and they also concluded that surgical treatment did not improve shoulder function outcome. Coming to the shaft humerus, this is a 21 years male, again, a recent fall, and he had a cardiac valve replacement about 2 months back. After a fall from a motorcycle, he sustained a fracture of the shaft of the humerus. So this was on day 1. And this was 1 week later. Still, we tried to manipulate the cast so that to get the fracture ends closer to each other. And at 3 weeks, we were able to see good or at least acceptable alignment. And at 6 weeks, there was a good amount of callus here. This is a child with a pathological fracture of the humerus shaft, secondary to fibrous dysplasia. Heals well in 8 weeks in a cast. This is an old X-ray. This patient had a segmental fracture of the humerus. I don't remember why we conserved him, but we'd given him a U cast, and one can see that in 4 weeks the position was still maintained satisfactorily, and there was some good amount of callus formation. There are many options to manage humerus fractures conservatively. You can use the hanging arm cast, you can use the functional bracing, the U-brachial splint, the Velpo dressing, and the shoulder spica, depending on where the fracture is and how you want to immobilize it. It's also easy to intelligently use the cast to correct the deformities and get alignment. This is a coaptation splint, and this is the Sarmiento's functional brace. The advantage of this brace is that the shoulder and elbow are free, and early mobilization of the shoulder and elbow can be started. This is a comparative study of the literature comparing intramedullary nailing, plating, and conservative treatment in fracture shaft humerus. If we look at the time to union, we see that they're averaging around 10 to 11 weeks for all types of management. And so is the percentage of fracture union. So all of them have very good and satisfactory results. But what's important here is the complication rates. The complications were highest with intramedullary nailing, followed by plating, and significantly low when it came to the conservative management. And functionally and time to union and percentage of union all remain almost the same. Coming to the lower limb, this is a spiral oblique comminuted fracture of the tibial diaphysis. Any opinions from the panel as to how to go about treating these fractures?
I would use a functional brace.
This needs a functional brace. Okay, sir. Because the fibula is intact here.
If you're using non-operative.
It is a comminuted fracture because of low velocity injury. So there's a good soft tissue cover.
Yes.
And so its chance of healing is much higher. But if you interfere this fracture with something, soft tissue dissection or something, it will not heal. It will create problem. So preferably such fractures should be treated non-operatively. This is my observation.
Okay, thank you. Dr. Claude?
Eventually, this will be a great case for PTV.
Yes.
Okay, yes. So what we did was I put him in a cast. If you can see, I've used a very thin layer of cast and a single roll of padding. We waited till the swelling went down, applied a very thin layer of padding and a very, very thin cast. Of course, it is strong. You need it to be strong. And this was at 4 weeks. And with 8 weeks, again, the fracture was, you could see the callus and also the fracture was not displaced. So, we went ahead with the non-operative type of management. I was wondering whether we should nail this, but my main concern was since all the fragments are well aligned, while reaming or putting in a guide wire or putting the nail in, maybe if those fracture fragments would have opened out, then probably would have been worse. This is an obese lady. She had an insufficiency fracture. She fell off from standing height. This is an intra-articular fracture, and she does require direct reduction and rigid fixation or absolute stability here. But she refused any form of surgery. In fact, I wanted to get a CT scan, and she said she doesn't want to get herself investigated as well. And she insisted that you only treat me non-operatively. So I applied a delta cast here. And at 4 weeks, you could still see the fracture lines. But at 7 weeks follow-up, the fractures had united. There was no intra-articular step. And I started, she was obese, so I was really worried about the cast holding and also when to start weight bearing. But yeah, luckily everything went well here. This is very interesting. We'll discuss this case with the panelist. This was a 22 years male. He suffered a grade 3 compound fracture shaft of the tibia. And he came to me after almost 3 months. So I hadn't seen him. I hadn't seen the primary injury. And he came to me when his external fixator was removed with the plaster of Paris posterior splint and pus discharge from 2 pin tracts. And this was the X-ray that I started with. So you can see that there are the pin tracts, and these were the 2 pin tracts from which there was pus discharge. The fracture did not appear to be united, and there was some anterior defect. And if you look carefully, you can also see the staples which are there here, and these staples which were used to hold the skin grafting, they also hadn't been removed. So my question was, what do I do now? Because there was a non-union to manage and infection. Of course, I had the option of nailing this fracture, but I was worried that this would spread the infection into the medullary canal, and plating was not really a preferred option. The third option, of course, since we are in a webinar for conservative management, but what is the opinion of the panel here in such a situation? I think in our setups we do get such patients, and I really had no clue what had transpired before that 3 months. Your comments, please.
So, if this patient came to me,
yes, sir.
Of course, the major problem here is the infection, and because we cannot use a method of internal fixation right now anyway because of the infection. So we have to worry about the infection. If we use internal fixation, we are going to spread the infection. So probably the way I would have gone is to use a ring fixator.
Yeah. Dr. Shah, Dr. Martin?
Yes, this is a infected non-union.
Yes.
And by principle, infection has to be controlled to achieve union. And both things requires full debridement for infection control, and then absolute stability for achieving union. And these all cannot be achieved by conservative methods because there is infection, and so we have to debride this thoroughly and then bring them ends together, compress it and fix it. 2 ways of fixing: either you can use a compression plate or you can use intramedullary interlocking nail also. We had a great series of treating this with a solid intramedullary nail. We call it a sign nail, and that is very, very strong system. And as it is solid system, this controls infection and this stabilizes fracture to a greatest extent. And but nevertheless, it requires very good debridement. So debridement and nearly absolute stability is the choice device. You can select what you have. Thank you.
Okay. Dr. Martin?
I would ask one more question is, the pin sites are draining, but is the fracture site draining? Is it covered?
The fracture site is covered. The fracture site is covered, and the fracture site is not draining. No.
So it may be that if you're lucky, the fracture site is not infected. Okay, if you're lucky. But I agree with Dr. Thomas that probably the best way right now is you have to get control of the pin site infections, and you'll most likely have to curette that out and debride it. But I'm not sure about the fracture site infection. But I agree that a ring fixator to stabilize, to obtain some type of temporary stability so that you allow for the soft tissues to settle down. You're not compromising your future treatments with a ring fixator, but you have to get control of the pin site infections first. And then it gives you a little bit of time for the fracture site to declare itself.
Right.
Unless he's septic, unless the patient is systemically sick, then you've got a little bit of time to let Mother Nature help you and to let the patient declare himself.
Yeah. Thank you. Actually, I got the cultures done, identified the sensitive antibiotics, and started him on antibiotics. Did a small curettage of the pin site, drained whatever I could, but he was not, ready to afford any ring fixator. That is the ideal choice here, to go in for an Elizarov frame. But he just said he can't afford anymore. He was very impatient because this treatment was taking too long. And I just decided that, okay, maybe I'll go ahead, like you just said, Dr. Martin, let nature heal the bone. So I gave him a well-molded polyester cast, and I started immediate weight bearing, thinking that it would improve the blood supply, also, initiate bone formation and heal the wounds. Maybe I was lucky. At 6 weeks, I could see that there was some bone formation there. There was some callus. And luckily, I was doing the dressings of the pin sites through the windows in the cast, and they also started drying up. And at 12 weeks, his wounds have reduced. The pain has gone down completely, and I see a good attempt to healing. He's still in follow-up, and I think I'm anticipating that he should do well. So this is one of those indications where I think in patients such as these, one can attempt a closed approach and a conservative approach rather than an operative approach. This is another example for comminuted metaphyseal fracture of the distal radius. This is undisplaced metaphyseal. This patient was advised surgery by two of my colleagues, but again, I think in our subcontinent, patients really prefer conservative over surgical management. So I gave him a cast, and at 6 weeks, he had a very good fracture union. Another interesting case, we'll also discuss this. This is a 42-year-old male, history of fall from a motorcycle, and he sustained this fracture in September last year. And he was in another city, but came down here, and you can see that he has a radial neck fracture. If I have to classify this by Judes, I would say this is type 1 Judes with less than 30 degrees of angulation. Comments from the panel. Instinctively, what do you think? Should we go in for a surgery in this patient? Dr. Martin? Yeah.
What is the patient's range of motion in terms of pronation, supination?
At this point of time, when he just presented to me?
Yeah. Was he able to,
it was painful. It was painful, and I really didn't want to push him through the entire range.
One of the things that I was taught, for wrongly or for better or for worse, way back, was that it was not a bad idea to aspirate the hematoma and put a little bit of xylocaine into the area and to measure to see what the patient's range of motion was. And if the patient's range of motion was not restricted as too much, was reasonable in terms of functional pronation and supination, there was no reason why you should treat this in any other way than non-operative.
Okay. Dr. Shah and Dr.
Yes, I agree with Claude that It all depends. If there is no hindrance in movement, then let it be. It is minimally displaced and articular surfaces appears maintained. So conservative treatment, early mobilization, as soon as patient becomes pain-free, just mobilize it, and that will make this fracture heal. Only thing is that this fracture may become displaced or may not heal. In that case only, you can try something else. Otherwise, at this moment, I don't think you should interfere.
Okay. Dr. Thomas?
I would always treat these patients non-operatively, and I wouldn't even use the plaster slab for this.
Yes.
The sling.
Oh.
Yeah.
Okay. Because my concern was, okay, I'm very happy that, all three of you think on the conservative lines. Yeah, sorry. Yeah.
I mean, India being a very litigious society, and I used to do a lot of medical legal review cases in orthopedics a long time ago. You must warn the patient right away that regardless of the method of treatment, he or she will lose some range of motion. Most of the time, they lose extension, okay? And I have seen not so many legal complaints, but complaints to the licensing authorities where patients were unhappy about they were told that they would have a lack of extension. In most people, it's not a big deal, but depending on the profession of the individual, it can be a big deal if they're left with a fixed flexion deformity of 30 degrees and beyond.
Yeah. Actually, I was very worried when he came to me, because I was worried that this might displace in due course of time. And he's a software engineer. And I was worried that if it gets displaced, so he might need a surgery somewhere down the line. So I did counsel him that I'll be managing him conservatively. But at any point of time, if I feel that this fracture is going to get displaced, then he would go in for an operative treatment. Let's see what happened. And then I got his CT scans done. Again, there was it showed some amount of impaction, but there was no angulation that I needed to be worried about. And this is 4 weeks in cast, still holding good. This is again a polyester cast. That's why the X-ray images are so good. And this is 8 weeks. So at this time, I was confident that I can take him to full treatment, to full union. But again, I was very worried about his movements. This is at 12 weeks. And this is 9 months. So the fracture had radiologically united in a pretty acceptable position. And this is his pronation and supination at 12 weeks. I was very satisfied with that. Flexion extension at 12 weeks. And this is his range of flexion extension at 9 months. This is at 9 months. This is something I've taken very recently. Full range. And this is his range of pronation and supination. So again, I think this patient was very compliant. After removal of the plaster, he was very compliant with physiotherapy, really took interest in physiotherapy, and that's why I think the good result. So after seeing these cases, I think we'll agree that there are certain prerequisites for us to look at before we proceed on conservative management. That is a good patient compliance. It's very important. Meticulous attention to detail on part of the surgeon. Weekly follow-up, at least this is what I follow, a weekly follow-up for the first 4 weeks, may not be 6 weeks, but for first 4 weeks to see the condition of the plaster, whether it's broken, whether it's loosened, whether the patient is following the instructions, and one X-ray to see if the fracture is still in the position that it needs to be in. The surgeon must have a thorough knowledge regarding the application of splint, braces, and plasters. He must advise mobilization of all non-involved joints. And I feel that cast application in very obese patients may be very difficult because it's difficult to hold the reduction in such a situation. So the advantages of conservative treatment are that it is cheap, it is safe, but very importantly, the experience of the surgeon counts. It's an effective method. It has proven clinical success, sometimes even better than operative methods. It is correctable. One can correct the displacements by wedging or conversion to splints or changing the position of the cast. It is versatile, it is biological, and statistically it takes almost the same time to union as with operative methods with minimal functional loss. And now let's look at something very important, that is the dangers of cast application. Since we've looked at all sorts of plasters, the most important one is plaster disease. And plaster disease was described by Dr. Just Lucas Champonnet. He was a French surgeon, and he described this in his book in 1893. So he describes that plaster disease is a disease that occurs after the application of plasters for prolonged periods of time, where the muscles, tendons, almost every structure beneath the plaster becomes disused, undergoes disuse or atrophy. Then the cast syndrome, especially in the hip spicas, that can lead to intestinal obstruction, deep vein thrombosis. We've seen skin allergies and plaster sores, thermal injuries during removal, compartment syndromes, and cast breakage leading to loss of reduction. Some clinical photographs here. This child had a CTV cast, and you can see the bad sore here on the back of his heel. This is plaster dermatitis for a below knee cast and lacerations and thermal injuries during cast removal. This child had an undisplaced fracture, a supracondylar fracture, and was given an above elbow cast in flexion, more than 90 degrees of flexion, and he presented after 1 week, and this was the scene when we removed the plaster. You can see a lot of blisters, severe swelling. We had to do a fasciotomy extending right up to the palmar spaces, and sometimes these cases can lead to Volkmann's ischemic contracture. This lady had a fracture of the calcaneus. She came to us after 12 days with a tight below knee cast, and it was very foul smelling. There was stain on the cast, and when we removed the plaster, she had a huge plaster sore and established dry gangrene on the toes. So this is one of the dreaded complications if the plasters are not applied properly. And if you choose the wrong patient, the wrong fracture, and apply the wrong cast, one can have bad results. This is segmental tibia, and this young guy was given a cast for this and left like this. So the cast had to be removed, and then we had to go on to operative management. And then someone tried to apply plaster of Paris to a Galeazzi fracture, leading to gross malunion and loss of function. So the conservative management and the non-operative management, like Dr. Martin was saying, is a lost art actually. It needs revival. And that revival can come only if people are interested in training themselves, improving their skills. We must have repetitive clinics in the hospitals, especially in the teaching hospitals, and raise the awareness of this method of treatment among surgical residents. We see a lot of courses that take place all around the world on operative fracture management, fixation of every fracture that is there. But we hardly see courses on conservative management, on proper techniques of cast application. I think it's time we should move in this direction as well. So friends, fascinating surgeries and market-driven evolving technology should not make us forget the time-tested and successful methods of conservative fracture management. And their application in practice should be judiciously applied. So the take-home message here is the choice of treatment should be based on location, morphology of the fracture, and the presence of associated injuries. One must understand the anatomy, fracture geometry, and the patient's activity and expectations when we decide how to treat his fracture. We must have a thorough knowledge and practice regarding the application of splint, braces, and cast. Always counsel your patients well, mobilize the uninvolved joints, ensure that they follow up and are compliant with your instructions, perform a regular radiological assessment, and always look out for any dangers. I'll stop here. Thank you very much. It's an important quote. Make Mother Nature your partner. She does half of your work and asks for none of your fee. Thank you very much. Thank you, panelists. I'll hand this over to Dr. Praveen now. Praveen, you can take over.
Thank you, Dr. Barik.
Question answer session. Yeah.
Thanks a lot for your session. I would like to thank all the panelists for an informative panel discussion. And I would like to thank all the participants, since I'm sure they must have had a great learning experience. And I can see a lot of questions from them, and we'll try our best to answer them within the limited time. So I would like to direct questions to the panelists and the faculty speaker, but it's open to the panel members to give their comments. So the first question is from Dr. Hemal Ratnaike. The question is, in a young patient of 20 to 40 years who has an undisplaced distal radius fracture and where the doctor has decided to go for conservative management approach, what should be the extent of cast or slab, whether it should be above elbow or below elbow? This question I would like to direct it to Dr. Claude.
You know, if it's an undisplaced distal radial fracture in how old the patient? 14 years old?
20 to 40 years old.
20 to 40 years old. Assuming that it's not comminuted, there's very little displacement. You know, you have to look at patient compliance, and one of the reasons why at least when I was in practice, we used to put patients in circular casts, is that we could not be 100% sure their patient was compliant. So a below elbow, well molded 3-point fixation cast, making sure that the fingers can move quite readily with a good exercise regimen for the joints above and below is the way I would go, with initial x-ray follow-up at 1 week, 2 weeks, 4 weeks, and most likely cast removal at 6 weeks. Now, in certain situations where you have a very compliant patient, you may start to remove the cast a little bit earlier and having a well-molded orthosis.
Thanks, Dr. Claude. Any comments from the panel members?
I agree.
Yes, that's perfect.
They all agree with me that I must do something correct.
So we'll move on to the next question.
Yeah.
The question is again from Dr. Hemal. The question is, what is the anatomical position basis when you're applying a cast for a forearm fracture? This question is addressed to Dr. Shah.
Yeah, forearm fractures, if you are dealing in adults, usually this forearm in children is different, but usually in children it is a greenistick fracture. So rotational element is not there. So it is straightforward, just straighten it and apply a cast, and that will heal within 3 to 6 weeks time. But in adult, usually it is displaced, and main concern is the maintenance of the radius bow and the introosseous space. If you are careful about that, if you can maintain the introosseous space and the radius bow after reduction, that is good. That anyway you can treat. So many times people are dealing with conservative methods, but by and large, these two things, maintenance of radius bow and maintenance of the introosseous space, is very difficult by closed methods. And so many people prefer to go for open reduction and plating, and people say that this is because this is behaves like intra-articular fracture. So we should go for open reduction internal fixation. So that is the viewpoint. If you can maintain it, then you can go ahead with conservative treatment. Otherwise, you need to fix it and early mobilization. That's the current concept.
Okay. So in the interest of time, I'll move on to the next question.
One point here, Praveen. There's something called the Canterbury Cast Index. So when you apply, especially in the forearms and in children, there are 2-3 important points that first is make sure that the fractures are not at the same level. They usually tend to have a high incidence of cross union. And like Dr. Shah just mentioned, maintaining the interosseous space, that means you need a Canterbury Cast Index of about 0.7 ratio between the anteroposterior and the mediolateral diameters. So that one needs to look at and regularly follow up to see if there's any cross union or displacement. Yes, sir.
If I may say something.
Yes, sir.
See, I haven't been treating forearm fractures except in children non-operatively for a long time. But when I was a resident, we were taught that the position, this is the question which Dr. Hemant asked, which position you should keep the forearm in. And we were taught that if it's a proximal fracture, you keep it in supination. If it's a middle level fracture, you keep it mid-prone, and a distal fracture, you keep it in supination.
Pronation.
I don't know if this is relevant anymore, but this is what we were taught then. It's a long time since
it's relevant, sir. It's relevant, but you're right that in adults, one should not treat them conservatively.
But basis of that is that you need to maintain the radius bow. And you need to maintain the interosseous space.
Yes.
By what methods you are applying?
I agree with you, Dr. Ram. Shah. The thing is that it's the question of what muscle is inserted at what point in the forearm.
Good.
Okay, moving on to the third question. This is from Dr. Pratap. His question is, during application of cast, he has come across a lot of materials of casting, be it plaster of Paris, fiberglass, or the latest one being polyester cast. So he wanted to understand, how do you choose the different cast material depending on the patient? He wanted to understand the benefits of each of these materials. So this question is addressed to Dr. Barik.
Okay. I think we moved now from plaster of Paris because though plaster of Paris is cheap, there are certain disadvantages like it's heavy. You need more number of plaster rolls, and maintaining skin hygiene is quite difficult in a plaster of Paris cast. Fiberglass and polyester, I think the main advantage of polyester over fiberglass is that the polyester cast is far more moldable. It conforms very well to the contours, so you can really give a very well molded cast. And depending on the percentage of resin that goes into the material, you can actually have something called as focus rigidity casting. That means when you apply more number of laminations, only that part of the cast becomes hard and the other parts can remain soft and pliable. And you're able to even change the amount of resin that is there, so you can choose between a soft cast and a hard cast. And the biggest advantage is if you're using a liner, which is nylon, then these patients can actually wash their limbs. They can actually go swimming. They can take a shower, and the plaster dries off in about 40 minutes. So I think the way to go forward is the polyester cast. And when we compare cost as well, if you're going to need 6 rolls of plaster of Paris, you can do exactly the same type of cast application with 1 roll of polyester cast. So even cost wise, I don't think it makes a huge impact. I mean, if you look at the benefits of and the biggest benefit I think to clinicians is that polyester casts are extremely radiolucent. All the X-rays that I showed today, they were with cast, and you can really see you really have very good radiographs.
Okay. Any comments from the panel members?
I think that Dr. Barik's comments are right on the money. Unfortunately, in a lot of the countries that I visit in Asia and in Africa, resin cast and fiberglass cast is non-existent. But if I had it my way, and if I could convince the authorities that it is much more cost-effective, treatment-effective, and in the end, much better for the patient, be able to apply either fiberglass or resin types of casts in the long run. There's no doubt about it. The initial problems with the fiberglass casts when they were just coming up was they were very difficult to mold. The material was very rigid, and the setting times were not known, and it was very difficult to get the molding that you want. But that has been pretty well resolved now. Okay, the cost remains a big issue, but the advantages are fantastic.
Any other comments from the panel members?
No, that's all been addressed.
So we move on to the next question. This is from Dr. Mahesh Prasad. His question is, what are the different methods of conservative management of long bone fractures? This question is directed to Dr. Thomas.
Okay. Different methods of non-operative management. It depends on the fracture site. Now, for me, if it was a humerus, I would generally use a functional brace. If it was a shaft fracture, I haven't treated it non-operatively for a long time, but when I was resident, we often braced these two with a hinge in between the upper segment and the lower segment. This was also a technique described by Sarmiento. It was popular at the time when I was a resident because the ability to do surgery was limited due to implant limitations and operatively at the time. If it's a tibial shaft fracture, at the present time, again, I would use a functional brace. I'm very familiar with using a patella tendon bearing cast because we did a lot of these when I was a resident. But right now, I think for comfort reasons, I would prefer a functional brace. So I don't know if I've left out any other long bone. So this is what I can contribute.
Okay. Any other comments from panel members?
I think I agree with what Dr. Thomas said. Yeah.
Yes, correct.
So moving on to the next question. This question is from Dr. Santosh. He says, in an emergency setting, when he's encountering problems of fractures or sprain injuries, he consumes a lot of time in application of cast. So he wanted to understand what is your experience in managing with synthetic splints, which are claimed to be instant and easy to use. So this question is directed to Dr. Barik.
Okay, Dr. Santosh, I think right now we have a lot of ready-to-use material. And it's always better to use that because, again, they are faster to apply, and you can actually apply the splint and then send these patients to radiology. So they being radiolucent, you also get very good quality X-rays, which was not the case when you were applying plaster of Paris splints. Or I remember earlier, even during my residency, we used to apply Kramer wire splints and things like that. But they would really come in the way of radiology. They were not comfortable for the patients. So I think ready-to-use splints are the way to go forward.
Okay. So in interest of time, I would like to move further. The next question is from Dr. Rishabh. He says, are the principles of conservative management, operative versus non-operative, are applicable even to children and elderly, or are they different for them? This question is directed to Dr. Claude.
I'll come back to the adage and the well-respected saying that children are not small adults, and that the premises for treating broken bones in children are completely different than adults. I think that in children, there are far few in between indications for operative management. The fractures of necessity are a good basis to start, but children are very, very forgiving, and all of you that have done your orthopedic residencies, you all see these cases of significant angulations in very young children, and it corrects itself. Mother Nature is very kind. Now, as the children get closer and closer to skeletal maturity, they become less and less children and more adults. So you have to look at all of the parameters of the patient, the injury, the skeletal maturity, what Mother Nature says will happen, and also the availability and the knowledge of treating certain operative fractures in children. You know, elastic nailing for femoral fractures, although it's been promoted as a panacea to not have kids in the hospital, it requires a very significant level of expertise. The learning curve is not easy, and it's not for everyone to use.
Okay. Any panel members would like to comment on this?
I think Dr. Claude covered it very well.
Yeah. So the next question is addressed to Dr. Thomas. The question is, how should we approach in a patient who is affected with fracture, but also a known case of malignant tumor, which is non-skeletal?
Okay, the basic teaching in a malignant tumor is the fracture due to the malignant tumor or not? That's the question I need to know. Does the questioner say the fracture is a pathological fracture due to the tumor, or is it a fracture it's not due to the tumor?
Information is not mentioned. Yeah.
Okay. Pathological fractures are supposed to be in a long bone, are by nature not usually treated by an intramedullary nail. They are very, very seldom treated non-operatively. Now, I can think of a situation where the patient is in a very terminal condition with a malignancy, where the surgery may not be possible, and then it would be treated non-operatively. But otherwise, they would be treated operatively simply for the comfort that an operative treatment affords, if at all possible.
Yes.
Okay. So we have another question. This question is addressed to Dr. Shah. The question is, what is the role of skin and skeletal traction in the present times? Does it have a major role?
Yes, traction has two roles. One is the preliminary traction for pain control in the emergency department. As soon as patient comes with, say, lower limb fractures, have femur, trochanteric fractures, you put in traction for immobilization and pain control. That's number one. Number two, in certain conditions, definite treatment by traction is also been applied, like many times undisplaced fracture of the pelvis also is many places, or minimally displaced fractures are treated by some traction. Then sometimes the minimally displaced fracture of the trochanter can also be treated by traction. And sometimes, especially in children, fractured shaft of femur below 10 years of age are preferably treated by traction. So traction are still in great use, and either a skin traction or skeletal traction. If you are using temporarily for shorter duration, you go for a skin traction. If you are treating definitively and for longer duration, then you go for a skeletal traction. But traction does also exist nowadays. Many times when you are working in a limited situation, even in open fractures of tibia, you can use a calcaneal traction, and you can use a Bowler-Brown frame and dress it, and that's also giving a good access to wound treatment and keeps that fracture aligned for some time when you are constrained by not having even external fixator in some of the deprived situation or very remote places. So traction as per se is still in use and is still very nice device to treat fractures.
Okay. Any comments from panel members?
I would say that the traction should be, as far as possible, avoided in elderly patients. It's very dangerous to use this method in elderly patients. Yeah. But in younger patients, especially in resource-constrained situation, as Dr. Ram Keval Shah correctly said, it can be used for nearly every lower limb fracture. And when I was a resident, we have treated fracture shaft of femur with this method. We have treated intertrochanteric fracture with this method, tibial shaft fracture, all of them, provided the patient is young. If the patient is elderly, this is a very dangerous method. So we have to
Yes,
remember that.
very correct, very correct.
In resource constraint, it's fine. I think the incidence of application of fractures to take traction till union is reducing a lot. And like Sir said correctly, elderly patients should not be put on traction because
Exactly.
they have a lot of problems with hypostatic pneumonias, bed sores, protein imbalance, a lot of things.
For those of you that play golf, you've got 14 clubs in the bag, and whether it's skin traction or skeletal traction, it's just another club in the bag that you need to know how to use. But you also need to figure out, where does it fit in the treatment? Is it temporary?
Yeah.
Is it transitional, or is it definitive? And I think those are the questions that you need to add. But it's just another club in the bag that you need to know how to use.
Exactly.
Okay, Praveen, I have a question that has come to me, and I want to put it to all the panelists. It's an interesting question. Is there a standard of care in conservative non-surgical casting? How should new doctors, I think he means orthopedic surgeons, how should new doctors learn conservative management? Or is it only by one's experience that one learns it? So he wants specially guidelines for young surgeons. So Dr. Thomas, I'll start with you.
I'm not young, and
You've seen both the worlds.
yeah, the thing is that when I was a resident, this was very explicitly taught to me in a very methodical way. So I can say that I learned this by training and not on my own.
What would you advise him?
Yeah, that's a problem. I would really say that in surgery, you need apprentice, whether it be non-surgical or surgical. In a surgical specialty, you learn by apprenticeship. It's very difficult to learn on your own. You make a lot of mistakes.
Yeah.
So it's foolish to make mistakes which other people have already made. That's the point of learning from experience and learning from a mentor. So I would strongly suggest that if at all possible, one should learn it from a mentor.
Dr. Martin?
Well, one place he can start is go to, and it's free, is just go to the AO Alliance website. Under the resources, there's a book, a PDF book that is entirely dedicated on non-operative fracture treatment.
Okay? Oh, great.
It's free. It's not password protected. You can download the chapters. You can copy them. You can send them to your friends. Second is, if you have time, is find an underserviced area that has a cast technician or someone that is very good at doing casting, and just go spend some time. Donate your time to help in resource poor areas. There are many in India and in other countries, and a lot of the times these people don't have a degree. They just learned the job on the job, but they've got a few gray hairs, and they are the masters of cast applications. And this is how I learned how to put on my casts. But it's a lost art because no one is doing it anymore, except in underserviced areas. But that's how we do. The other thing is, AO Alliance do put on some non-operative fracture care courses. But unfortunately, they're not in India. They're in 7 other countries in Asia Pacific, as well as in Africa. But there are some courses that still exist. But just like anything, you can't learn pelvic and acetabular surgery in going to a 1-week course. Just like you can't learn proper casting techniques in attending a 3-day course.
Okay. Thank you. Anything to add, Dr. Shah?
Yes, this is a good issue. You have to first know the principles that by non-operative methods also fracture can heal. People, especially the youngsters, have been, blasted with so many information that only surgery can lead to union. So that's first thing we have to understand. And that comes through proper learning the techniques and the results of the non-operative treatments, number one. Second thing, I agree with George.
There's interference there. Hello.
There is a disturbance.
Praveen.
Yes, Dr. Barik, I'm trying to address that.
Yeah.
Yes.
There is some disturbance. Hello.
Yes,
yeah,
sir,
please go ahead, Dr. Shah.
Okay. So, and second thing, I agree with George that you need to practice this. Like you need to practice for intramedullary nailing. You need to practice for tension band. So why don't you practice for plaster application or traction application? Apprenticeship, what George has said, this is a very right word. So now, gradually there is a revival and resurgence of these non-operative methods. And so there are a lot of teachings, lot of materials are available. Like Claude said that at AO Alliance site, there are a lot of materials available for learning. So you can find them on YouTube, you can find them on websites, and you can start learning, but you have to practice and to get it perfect. And then you can treat those fractures. But only thing I would say that be aware of the bad effects of plaster and traction. First, know them, the complication as well. And then you can prevent those complications. And that is the key to proceed for non-operative fracture treatment. Rather than creating complication, do not create complication. So you have to understand what are the possible pitfalls and complications of non-operative treatments.
Okay, thank you. There's one question. How do you prevent itching in cast?
Okay, itching in the cast. Itching in the cast is it's a sensation, it's a feeling. Sometimes nowadays what is happening that we are also using the synthetic materials.
Yeah.
Like even cast padding is synthetic.
Yes.
And even cast is synthetic. So if we avoid those things, synthetics may cause allergic reactions. But it's also known that plaster of Paris also sometimes, rarely can cause allergic reaction. So if there is any allergic manifestation, then just remove it and try something different material. Or otherwise, there is no other remedy. You can't put inside any powder or inside any medication. Sometimes there are bugs inside, sometimes ants inside. So just remove it, clean it, and reapply it.
With plaster of Paris, we used to, earlier during my residency days, we used to apply cotrimoxazole powder, candid powder.
No, sir. Let's not use anything underneath the plaster now.
That's what I want to say.
That is the teaching now, that you don't put anything, pour anything, do not prick anything, any stick or anything underneath.
Correct.
Just remove it, apply it again.
Yeah, or I give my patients tablet cetirizine for 2 to 3 days. So 5 days.
I don't think so. Just removal is the main thing.
Yeah, if it is persistent,
persistent, and you are sure that it is not causing, then change the material.
Yeah.
It may causing allergic.
But with synthetic cast and synthetic liners, one can just wash it, and I think it goes away.
Yes,
what do you say, sir?
Yes.
Dr.
Yeah,
Thomas?
that's right. You can try that.
Okay, Dr. Barik, you have further questions from the participants?
No. That's all. I just had these two questions.
So I have a few more questions at this end. So there's one more question from Dr. Satish. He agrees with the discussion that while applying fiberglass cast, he encounters problems because of non-conformability and the problem of having rigid, sharp edges. So he wanted to understand, while cast removal, he also faces some difficulty, especially the fumes which come out when you cut the cast. And he heard that it's very harmful to the doctor as well as for the patient. So what's the alternative for this? Are there any other solutions available? This question is directed to Dr. Barik.
Okay, we don't have the very latest plaster cutters where they have a vacuum attached to the saw, to the oscillating saw. So when you're removing these fiberglass casts, that actually helps. So that sucks off everything. But that equipment is expensive. I've seen it in some foreign countries, but we don't have it in India. I haven't seen it here. I think the best thing is you basically score the cast and then use plaster spreaders and a scissor to cut the liners. And luckily, I have some 3-4 very good BSN scissors. These are German scissors, and they can really cut through fiberglass and even the polyester casts. The polyester casts are a bit easier to cut, but to protect yourself from the dust that comes out of fiberglass, I think I just wear a mask. There's no real practical tip I can give. I don't know if Dr. Martin or Dr. Thomas can add to this.
It's just like drilling a hole. A dull drill bit generates a lot of heat and takes a long time. So it's very important to have your saw blades as sharp and as new as possible. That decreases the amount of time and decreases the fumes and decreases the heat. You have to be patient. You have to be patient, and as you said, if you have the luxury of having a vacuum attached to the cast saw cutter, it's a great addition. But many places don't have it. You just have to be patient. Take your time.
Okay. I have a request with the panel members. So already we are behind the schedule. So is there a possibility to extend for a few more minutes? We have a few more questions still need to be addressed. Is that okay with the panel members?
Yeah, we can go.
Yeah. So there's one more question from Dr. Kasim. His question is, there are different morphology of fractures. It could be transverse, oblique, or spiral. So in which of this morphology it is more suitable for going for non-operative method? This question is directed to Dr. Thomas.
We know that the spiral fractures are low energy, so they are the most suitable. Transverse fractures are high energy and are easily displaced, so they are less suitable. That's how it is.
Any comments from the panel members?
Yeah, same.
Okay. Moving on to the next question. It is addressed to Dr. Barik. The question is from Dr. Kasim. He says, in fibrous dysplasia, is it sufficient to go for immobilization by plaster of Paris?
Yeah, they have seen to be heal very well. So I really cannot generalize that. But especially in this situation where we had this, and he was a young child. So I think both the factors worked well. Fibrous dysplasia. I don't know if Dr. Thomas, Dr. Shah, or Dr. Martin would want to add to that.
I can't say in general. I think that the problem is not about the surgery or the non-surgical treatment, but already the pre-existing disease. So it should work, non-surgical method.
Yeah.
It's not uncommon to lesions that once the fracture heals, the lesion disappears.
Yeah.
Okay, that is not uncommon to happen.
Okay. The next question is from Dr. Shishir. It is addressed to Dr. Thomas. His question is, what is the percentage of humerus shaft fractures which go for conservative treatment as per your experience? And what is the healing rates by the conservative methods?
This definitely depends entirely on where you work. I spent a considerable period of my time working in the government sector. And at that time, the percentage of humeral shaft fractures which were treated by a non-operative method was, I would say, around about 85%. We would operate only those which were absolute indications for surgery. For the last 12 years, I've been working in the private sector. Here, the situation is different. There are other reasons to operate. I'm not saying only about earning money here, but there are the patients who see the problem in the government sector was that even if the patient would prefer a surgical method, we had lack of time. We didn't have enough operative time. We didn't have enough implant. It was expensive. So there were restricting factors. In the private sector, when the patient is paying and they choose the treatment, my experience is in the last 12 years that I've been in private practice that a lot of the patients who come to me, it depends on their financial situation. So they choose the operative treatment depending on their financial situation. And I would say that the operative treatment has gone far higher than this is the only honest answer I can give. I offer them both, but they generally choose the in the government sector, we were not offering them that because we just could not make that offer since we had other constraints. So we would say that you need a plaster, and it would be okay. And generally, they had no option to choose. But in the private sector, where they have the option to choose, it depends on what job they do, what their financial situation, and how soon they want to get back to work, and comfort of the treatment. So the operative surgery has gone up very much. That's the best answer I can give you.
Okay. Any comments from the panel members?
I have a very interesting statistics. I know 5 orthopedic surgeons who themselves had fracture shaft humerus over the last 10, 12 years that I've seen. And all of them went for conservative management. Orthopedic surgeons themselves. So, but I fully agree with what Dr. Thomas said. It depends where you're working, and I think the choice is largely dictated by the patients.
Okay.
Yes.
So moving on to the next question. This is from Dr. Ravish and directed to Dr. Barik. His question is, what is the best practice in terms of cast application? Is it necessary to apply stockinette as a first layer before you apply padding and the cast material? Okay.
If you're using plaster of Paris, I think it's good to apply a stockinette. But if I'm using the synthetic liners and the synthetic cast, I don't apply a stockinette. Even though in most of the trainings that I have attended, they apply a stockinette, and they say that even if the patient has a shower with the stockinette, then the synthetic liner and the synthetic cast, the drying times are the same. But I have personally experienced crumpling of the stockinette inside the cast, and that has given rise to a lot of irritation, for which I had to change the cast twice. So I have stopped applying stockinettes. This is my personal opinion. So I just apply the synthetic liner and the synthetic cast, because the stockinette is cotton. So unless you're using a synthetic stockinette, that's a different matter. You do get synthetic stockinettes as well. Anyone else would like to add to this, their experience?
No, that's all right. I mean, because as we have been increasingly cast pad used to have a cotton stockinette to reduce any allergy or any irritation. That's the main objective. It does not serve any other purpose. So whether you use it or don't use it, it's okay. But mostly, especially in the European setup, people use a stockinette because their skin is very delicate. Their skin is very sensitive, and that's why they try to protect all any irritation or any problem. So otherwise, as Dr. Barik is saying, that's correct.
Okay. We have another question from Dr. Qasim. This is addressed to Dr. Shah. His question is there any time difference of bone union when it compared to operative versus non-operative?
No, bone healing timing is the same. This is a natural process. Only thing what we, by any treatment, either conservative or operative, what we are doing is we are reducing the disturbance of healing. So if it is reduced and if it is well stabilized, either by any methods, then healing will go on undisturbed, and that will heal in equally time. So time is only, people say blame that in non-operative treatment, it heals in a longer time, and it is not like that. Healing is a natural process. It will heal at the same time. Only objective is how best you are reducing the factors of redisplacement or factors of instability. So if cast is stabilizing the fracture well and fracture goes on healing undisturbed, there is no delay in healing.
Okay. I would request Dr. Barik if there are any questions from the participants through WhatsApp.
No, there's nothing. There's nothing.
Yeah. So I think in the interest of time, I think we might have to close the session.
Yeah.
So I would like to thank the speaker, the panelists, and all the participants for making this session a great learning experience.
Thank
and I'm
you.
sure the young surgeons would have learned a lot, especially about the non-operative management. And we look forward to your participation in the next webinar, which is coming on 23rd May from 1 p.m. to 2 p.m. on novel splinting techniques in extremity injuries. So as I said, this is the first such program in a series of programs happening every Saturday, 1 to 2. So if you look at the screen, we have distinguished panelists and speakers as a part of this session. We have 2 international faculty. Speaker is Olaf Kand from Germany. And we also have Dr. Nandkishore S. Lord from Mumbai, Dr. Rishi Best from Nepal, and Dr. Klaus Dressing from Germany. So we hope to see you in the next webinar. And thank you and stay safe. Thank you very much.
Praveen.
Thank you all.
Thank you.
Bye-bye.
Thank you.
Yeah,
Thank
bye.
you, sir.
Bye-bye.
Thank you
Have a
very
nice
much.
time.
Thank you, Dr.
Thank
Martin.
you all.
Doctor.
Thank you.
all.
Thanks. Thanks.